I grew up in Toledo, Ohio, and I was the oldest of 6 in a Catholic family with all Catholic education. And I think I was a traditional firstborn, and heavily motivated, good in school, just, I think, eager to be successful. And then I went to college, first at John Carroll University in Cleveland, and then transferred to DePaul University in Chicago and got my bachelor's in nursing. My brothers and sisters all are wonderful, unique humans who have done incredible things. My dad, he worked very hard. He was in the car business, and he really wasn't home that much during the week. My mom was a nurse, and she came from Jamaica, and the island of Jamaica, and she wanted to be a nurse in World War II and went to the Cadet Nurse Corps. And by the time she graduated from her nursing school in Toledo, Ohio, the war was over. So, it was always kind of interesting to have a mother from another country. And she was the touchstone of our lives. I mean, till the day she passed away, I think all of us called her at least 3 or 4 times a week. And no matter, we all live in different parts of the country. And so it was a very, I think, a very mother-centered environment. But real hard work ethic. My dad was an incredible provider and worker, and every one of us has a very good work ethic. It was interesting. She had her 6 kids, and when I was in 8th grade, she decided to go back to nursing, and that was right when intensive care units were beginning. And so she'd had about a 12-year hiatus, and she went back and worked nights and became the supervisor of the intensive care unit, the first intensive care unit in Toledo. And I just, her dedication was incredible. Of course, I told her I would never be a nurse, and I also told her I would never join the Army. Things happen. And the moral of that story is never say never to your mother. I was going to be a physician, and I was going to be a surgeon. And honestly, I didn't think nursing was going to be for me. So as much as she tried to encourage me, because I was really, heavily engaged with science. I love science. Always doing science projects. But in years to come, when I went to college and I was sort of confused. I started out in pre-med, then I didn't like that. I went to psychology. And then I took a year off and tried to think of what is it I want to do. And I said, I think I want to be a nurse. There's something about it, the more I learned about it. And I went to the hospital with her, and some of her physician colleagues kind of took me under their wing during that year. And I got to have an exposure. And then when I got to my final 2 years of college, I was a driven nursing student. I ended up taking my junior and senior years concurrently. And it, was the beginning of a great adventure. I went to an all-girls Catholic high school, very cliquey. And watching the kids who weren't in their cliques was really hard. It was not okay to be mean to people or to leave them out just because you didn't want to hang around with them. And that just, I felt, it was like that empathy of, it's not okay to be mean to her. Or, so that always bothered me in high school. Other than that, I didn't have any huge moral dilemmas growing up. I don't mean to be so mother-centric, but my mom was an incredible role model. And to this day, it's like, what would Mom do? I should have that on my car. When I think of how she mentored and nurtured the young nurses under her, and I can remember at Christmas wrapping like a room full of little gifts for all the staff at the hospital, because then she became the supervisor of all the ICUs. And at her funeral, it was amazing, you know, when they ask people to come up and say, you know, do you want to remember Gloria? The stories. I would never have had my master's degree if your mother hadn't encouraged me. You know, I wouldn't have gone and gotten a heart transplant. Whoa, Mom. So the way she touched lives, probably not even realizing it, and her selflessness. I think that's my first real insight into what selflessness is about, you know. So she definitely is my number one role model. And she cared about other people being successful. And so her success wasn't in what she did. She kind of looked at what nurses went and got their bachelor's, you know, what nurses went on and became specialists in an area. And those are the successes she would talk about at work. Never I. She never talked about I. So, you know, probably selfless to a fault. She could have taken a lot better care of herself, but, you know, definitely a hero in my mind. I did my clinical rotations at University of Chicago. DePaul did, which is a huge research hospital. And this was in the 70s. And so we really, you know, I didn't know anything about IRBs, but I knew about research protocols. And then when I graduated from college, I went to work on the transplant unit at University of Chicago. And back in those days, transplant was research. It wasn't standard of care. And we didn't always work off protocols. And it was sort of each patient was their own subject. And you know, they made the medications and in the back in the lab. And it was a different day. But I think that's my first taste at advocacy as a nurse, advocating for your patients, and watching someone, you know, a patient be at the center of a lot of activity and maybe not really understanding what's going on. And, you know, I was a staff nurse, and so I was just doing. But I knew that, you know, this patient was having a rejection, so we needed to treat him with steroids and really powerful immunosuppressive drugs. But there wasn't, you know, we weren't working off guidelines. And it was sort of, everything was individual. But it was the powerlessness of those patients. And really, if this didn't work, you know, we had dialysis, but in those days, the immunosuppression was so powerful that you just blasted their immune systems, and they got overwhelming infections or bad complications from steroids. And so it was there was a high mortality, and the morbidity was significant. So that was my first, you know, taste of research. University of Chicago decided to hire bachelor's prepared nurses. I mean, not that we're any great shakes, but there was a lot of, I think all of us really had the patient at the center of our attention. You know, we weren't really tuned into the research as much, but those patients were hard to care for. They had a lot going on. And you were very careful not to make errors, and you were very careful to report things early that were happening. And you just always had your fingers crossed. Is this one going to make it, or is this transplant going to be successful? There was so much uncertainty. Would those patients, had they had this, you know, a 10-page consent form explaining all the things that were going to happen to them, would they have made a different choice? And I don't know, but I don't think so, because they were so desperate to get off dialysis. Also, dialysis was very hard back then, and there was a high mortality on dialysis. And so they really had two not great choices. And so, you know, I don't know, probably a highly educated person might have done a risk-benefit analysis. But a lot of the patients we were taking care of were from the south side of Chicago, you know, and many diabetics, many African-American diabetics. So, you know, I guess I wasn't really tuned into their rights and welfare at that point. I just wanted to make sure that somebody was thinking about them they were at the center of the decision making. And I went and got my master's in nursing.
Immediately?
No, a couple years later. And I went to University of Illinois at the medical center there in Chicago. And they used to call us clinical nurse specialists. And then I went back to transplant, because there was something about it that was, those patients required so much nursing care. Because the transplant operation and immunosuppression was one part of it, but living with the transplant for however long you got to live required a lot of education, a lot of modifications to your lifestyle. And that's where I saw my calling. I got very engaged in transplant, and I wrote a book chapter, I wrote articles, I did my own little study, and I got to give a paper at the Eurotransplant meeting in Leiden, Holland, and I fell in love with Europe. And I thought, I would like to live over here and work. Plus, I had been carrying a pager 24/7. That, and the ups and downs of living with that transplant population took a toll on you. I mean, you lost so many patients. Patients lost their transplants and ended back on dialysis. And it had been a fairly intense set of years. And so I had a friend at University of Chicago who was also a ClinSpec. And I don't know what motivated her to join the Army, but she did. And so she wrote me a letter from Frankfurt, Germany, and she said, "You have to do this. First of all, it's, the work isn't as hard as what we're doing at University of Chicago, and Europe is beautiful, and it is just an amazing experience." Well, I had never camped. My sports were like tennis, not running, certainly not push-ups. And so I went and talked to a recruiter, and I said, my goal is to live in Europe. And so if you can guarantee me an assignment in Europe, I'm in. And I thought to myself, I will do this for 3 years. And I can do anything for 3 years. And I really want to learn more about Europe. So I told my mother, who was thrilled. My brothers and sisters thought I had been, had a head injury or something. They just couldn't believe it. And they gave me Heidelberg, Germany as an assignment. And so I was sworn in at University of Chicago. They had a farewell for me. And I thought, okay, I'm on an adventure. And as long as I'm having fun, I'm in. And I joined the Army, and in the Army, Nurse Corps, you start at the bottom. You start as a staff nurse again, which was fine. I had a whole lot of responsibility previously and a very intense job. And being a staff nurse, I'm going to be the best staff nurse you've ever seen. And getting to live in Heidelberg, Germany, and taking care of soldiers who were just delightful. And this little ward, it was a small medical activity, and the soldiers made their own beds. And because they couldn't go back to the barracks if they were sick, if they'd had like a hernia repair or something, I was on a med-surg unit, they would stay in the hospital, but they were well. So you'd have them putting charts together, and I thought, this is amazing, and I get paid for this. And so, basic training was like being in a movie, and it was an adventure. And over time, it just became, and the Army values, it's a values-driven organization. And I believe in those values. And so it became, I found a home for my value set, and it worked for theirs. And so it was an amazing 4.5 years in Germany. They ended up letting me extend with great experiences. I said, okay, this has been awesome. I've traveled all over Europe. I've had a really good time. But I can do more. I can get back into helping with transplant patients. And so I had to go to the Army Advanced Officers course. And then I went to Walter Reed and worked of course, the Army, you ask for something and it may not be what they need you to do. So that there's the needs of the Army come first. And so I worked on head and neck oncology, which I thought I don't know if I can do this. But those were the most amazing patients, that had, and at that point, this was again in the early, like mid-'80s, there was fairly radical surgeries for those diagnoses, and so those patients had, had been smokers, and they're largely retirees, veterans, and I got to learn to love that population. But then they did put me finally on the transplant unit, and I spent a few years there, and then the Army asked me to go to their personnel command and help make assignments for Army Nurse Corps officers. And that gave me another perspective, worked closely with the Chief of the Army Nurse Corps at that point. And I decided I was going to apply for my doctoral degree. I thought research is what I like to do. I need tools in my toolkit, and I knew some really good nurse researchers in the Army, and I thought I'm going to go for it. And I put my application in and was selected, and the Army sent me for 3 years full-time to the University of Maryland to get my PhD in nursing with a concentration in health services research. So I work in the Army's, it's called the Army Medical Research and Materiel Command with an E, and we are the Army's command that both conducts and funds medical research. So the government has seen fit to give the Army the responsibility for running huge research programs. The congressionally directed medical research program that funds breast, prostate, ovarian cancer, and then since the war, many very warfighter, soldier-focused types of research. And my office provides both the human subjects protection regulatory oversight and the animal welfare oversight for those studies. So we oversee, and I'm the director, we oversee about 3,400 human research studies and the same number of animal studies. We have multiple programs. So the breast, all the kind of organ or disease-focused programs will benefit everyone. And actually, even the warfighter or soldier-focused research isn't even right now benefiting the public health. So what we've learned in combat casualty care, what we've learned in rehabilitation and prosthetics, in resuscitation, what we learn in military research benefits the global public health, really. So it's an honor to be there. And I actually got assigned there as a colonel, a lieutenant colonel, then a colonel. And honestly, I wasn't real excited about the assignment. I thought, regulation, me, really? I want to do research. But as I said, the needs of the Army. So I was actually programmed to go to be an assistant director of a research program at MRMC. That's our acronym. But because of timing, someone else got the assignment, and I got this assignment. And I never, ever, ever expected it would become like a labor of love, and it would have been the right place at the right time. So it was in 2002. We were at the beginning of the war, and I honestly, I don't think I knew what I was doing. I had been an IRB member. I had been on scientific review committees. I knew about IRB functions. But providing this level of oversight at this range of studies, and doing it in a way that we weren't grading papers, we were trying to help people get to yes. Because they'd already been scientifically reviewed, they'd already been programmatically reviewed. Now we had to ensure they complied with all the DoD regulations, and there's extra DoD regulations. And our job was to help these people do it right. And so it was huge,
How would you characterize How would you characterize the difference between research that takes place in the military compared to research that takes place in the rest of the world?
Well, I think they are far more alike than dissimilar, but there's a lot of misconceptions. So, and if you're thinking research with the military, like research with the military population, you know, a lot of people think, I'd really like to do research with the military population. They do what they're told. They're very orderly. They, you know, it's gonna, everything will just go like clockwork. And in the DoD, we're very, very sensitive to the hierarchical issues that are in our system, and that a basic trainee or a private, you know, they're pretty powerless. And but I always make the case that we don't hire people, or we don't allow people to join the military to make them powerless. We need them to be autonomous thinkers. We need them to be problem solvers. So there's a tension, you know, you've got this rank structure, and then you have, and you know, people who are doing research, if they're active duty, tend to be higher rank. But we take great pains to ensure that the voluntariness of this. So like if, let's say for example, you're gonna talk to a group of soldiers and you want to recruit them into a vaccine clinical trial because, and this was a real case, we have a type of pneumonia that is occupational hazard in basic training. And we used to have a vaccine for it, and it went out of manufacturing, and we had to bring it back. So we had to do a clinical trial with basic trainees, to me the most vulnerable because they're scared. And we have ombudsmen there. We take great pains to ensure that they each have an individual consenting experience and are able to ask questions, change their mind. They don't feel that this is part of joining the Army. You have to roll up your sleeve and be in research, you know. So, I use every opportunity I can to dispel those myths of involuntariness in research. There's websites that and patient advocacy groups that believe we're doing secret research, that believe that the war we used as an excuse to do secret vaccine research, which is so not true. And you know, I honestly, I think I would love to invite everybody to see how we do research, because I'm so very proud of how we do research. And this notion that we can order someone to be in a study is just wrong. So, you know, I think we are a great population, because if you're studying, let's say something like, any disease that has a confounding factor of socioeconomic status or access to health care, and then you study that disease or condition in the military, you know that they all have access to health care. And and although at lower ranks that they're not, you know, very well off, hopefully nobody's on, you know, so socioeconomically deprived that that's a risk factor, although it's possible. So, you know, it does have, you know, it's a heavily male population, and but yeah, people would love to do research with the military. I run an organization with 59 people. And we have different branches that do different things. One branch runs an IRB. And so if I look at the hierarchy of needs, it's to make sure everybody has their job and that we are secure with budget, and that so the business operations of keeping our enterprise going lately, especially with all the challenges with sequestration and budget cuts, has taken a lot of my time. Then looking at our processes and, you know, making sure, or keeping us on a road to being smarter, better, faster sometimes, better stewards of the government's money, problem solvers that don't sit on problems, because when we sit on problems, it's costing a researcher money. And we sort of a motto, every day counts, that our goal is to get through this review process in a timely fashion, but do it well. So I will be reviewing protocols. I'm actually still reviewing protocols. And I review work that's done by others and approve it. I get tapped to talk about the hardest ones, the no good answer ones, maybe we need to get research ethics advisors ones. And there's a lot of tough problems. And so, and then listen and grow the folks that work with me, help them be great leaders. And so I love my job. I have the best job in the Army because I get to see great research and work with great researchers and a staff that is very dedicated. So I feel like Joan. Health services researchers, probably a great span. They also call them clinical epidemiologists, but we're generally large data set researchers. So looking at the power of data to tell you what's happening. So I'm not a clinical trial. I've done intervention things, but my first love was to go to the medical record and ask the medical record questions about what might be associated with what. So for my doctoral dissertation, I knew a huge quality of life aspect in transplant, so I can't quite give up transplant, was that fact that they were readmitted so often. And what's the point if you are so sick that you just have to keep coming back to the hospital? What if we knew what was associated with readmission? Could we then early identify those people and maybe implement a program to prevent readmission? So that was my dissertation, looking at a lot of risk factors and looking at 30-day readmission. And then in the military, I looked at things like what factors affected women's ability to be successful in having physical activity in their routine. When we opened up DoD healthcare to retirees who were Medicare eligible, I looked at aspects of their health related to their healthcare utilization of the hospital. So, and then in the Army Nurse Corps, when you're a nurse researcher, and I finally ended up back at Walter Reed as the head of nursing research, your job is to answer the questions they need you to answer, and it may not be in your research tradition. All their questions weren't about big data questions, and you help the nurse researchers that you're working with answer questions. So you kind of become a Swiss Army nurse researcher. You got to have a lot of tools in your toolkit. And so I worked with great colleagues who were asking questions about med errors, who were asking one really great young researcher, he identified that testicular cancer there was a little blip, and it looked like it was an increased prevalence in the military. And what could we do about teaching soldiers to do testicular self-exams? And so I said, well, let's write a study, but let's not just ask who does it. Let's do an intervention. We decided to put a grant in to make a film to educate soldiers about and see if the film worked. And we ended up getting an instructor from West Point who, because he early identified that he had a lump, was able to maintain, save one testicle and early treatment. And he agreed to be the star of the movie. And the whole little film was about, and he was a helicopter pilot, and he talked about pre-flight checklists. And, we began in the hangar at West Point with his helicopter. It couldn't be more perfect. And it certainly was macho, and it was, and it turned out that, the subjects who had exposure to the film knew more about testicular cancer, and they said they practiced at TSE more often. So, then that was an opportunity to work through others. You can have your own impact, but if you can impact others to be successful, then you've life is better.
Do you have a personal mission statement or goal that you bring to bear on your work?
Wow, I never thought about that. I think if there's one, and I know this sounds so simplistic, but it's do the right thing. When it's like a mantra in our office, when we get the toughest questions, and we just say, we have to do the right thing. We have to. We have to have moral courage. And I think it doesn't matter what your profession is. Having moral courage is really hard. And sometimes the easy road is just so many less ripples and third and fourth order effects that are not there, but you have to do the right thing.
Is there anything in your career to date that you are particularly proud of that you and or your department or your institution have accomplished?
I have to say, there is something, I mean, there's a lot of things, but the big thing was in the beginning of the war, when we were going into Baghdad and we're setting up hospitals, and these were devastating injuries. And we really were dealing with doctrine that was from the Vietnam War. And it was a different war. And many astute nurses and physicians and others recognized that we need to collect data for research. And we didn't have a human research protection program for a combatant command to be conducted in a theater of operations. Well, because we recognized that it was going to be important to collect and analyze these data, and this was pre-HIPAA, this is 2002-03, and but then HIPAA came, and that we had to honor those rules and those DoD requirements to be able to do this. So a number of folks put together a proposal for how we could propose, review, oversee, and conduct research in the theater of operations, and do it responsibly. And so that plan took a lot of doing, put together, and we were able to get an assurance for the Army U.S. Central Command. It's not Army. And then recognized, well, everybody over there is gainfully employed taking care of patients. And we need to have people who are dedicated to collect these data and propose these studies and design them and have them scientifically reviewed so that whatever we were trying to study, we were using the appropriate methods and we could have confidence in our results. And so following the assurance in the HRPP, we put together a deployed combat casualty care research team. And now it's called the Joint Combat Casualty Care Research Team. And every 6 months, volunteer service members with various backgrounds, but some with research, go over and continue these studies, start new studies. And our last team, I think it's Team 16, will deploy here shortly in December. And we've been able to learn really important things from all the data generated by this conflict.
What kind of things are being studied?
Oh my goodness, it's everything from observational studies in the emergency department about blood product utilization, studies that can be conducted with consent about burnout, about of providers, that sort of thing. We had a fantastic Navy investigator who looked at with consent folks with mild TBI and MRI signature patterns, and to see if there is a image that could help us identify aspects of TBI. There's just been so many. There's studies of personnel. There's study of trauma care, pre- and post-deployment biomarkers. And it's been a huge team of teams, and really dedicated people who wouldn't take no for an answer. And so I was inspired by working with those folks who saw the importance of it. And now what we want to do is make sure that this goes into our doctrine and that we have this capability. Unfortunately, if we ever are in this, situation again, that we do think research right away and we don't lose those data, but always respecting the rights of those service members.
Well, you mentioned that your personal mission statement is along the lines of do the right thing.
Mm-hmm.
Is that an ethical frame of mind, do you think, can be taught, or is somebody born with that?
I think you can. I think you probably grow up with some of it, but you can be taught, and you can watch role models be successful with it. Watch folks take the hard road, but in the end it was for the right reasons. And I've watched, and I can think of some real physician heroes of mine in the military who took a hard road and suffered for it, but in my mind they did the right thing.
Have there been times when you have been uncomfortable or troubled by situations that you've seen in general in research?
Oh, sure. And you have to be careful that it's not hindsight driven, because who knew? But I have a great concern about research in underdeveloped countries sometimes, and we fund laboratories in Kenya and Thailand. And Kenya is such an amazing country. They're such wonderful, amazing folks. And it was my first experience going to hospitals without crash carts. And you think, how can this be? And consent is always a concern for me. And when I see what the IRB is reviewing and these very complicated technical consent forms for, treatment or vaccines, and I wonder, how could I understand that? I don't even sometimes understand it. So I get very concerned. And it's only by talking with the research ethics committee folks in the country that I understand how they're dealing with it. And you have to reconcile yourself between what our expectations are and what the reality on the ground is. And so I believe they're compliant with the spirit of what we're trying to do. Well, certainly this meeting here has driven home the therapeutic misconception is alive and well, and I don't know how we can get away from it, but it troubles me when I see the reports that even though you've taken great pains to explain that one arm is you're not going to get treatment, you're just going to be watched, and the other arm you're getting active treatment, and folks don't understand that, you just, it breaks your heart to think they believe they're getting the best treatment when in fact it may be just they're being observed. So I think if we could make consent more meaningful. And I think throughout this whole enterprise, meaningfulness as I get older is the most important thing to me. And quite honestly, enforcing some of the regs really bugs me because I don't believe in some of them. And I know it's probably heresy, but and they don't make sense in certain situations, but there's the letter of the law. And so that tension between what you want to do and what you have to do regulatorily sometimes is tough. But consent, absolutely. And I don't know, I don't think we can expect patients or subjects to become scientists, but in plain speak, with diagrams or with just, and I don't even know if tests of understanding tell you the whole story. But I like that people are continuing to study the actual consent process, and perhaps they'll come up with some great insights on how we can be better. I would like the person on the street to know that we are absolutely dedicated to getting it right, to doing it well, and our service members are precious, precious commodities. They're not commodities, they're precious entities, and we have to respect them, and we do respect them, and we have actually additional protections. So, for the critics who don't know, I'd invite them in and take them, have them watch a study or see the added pains we have to go to, we want to go to ensure the voluntariness of their participation. And sometimes, in the justice principle, they're the population that stands to benefit. What we're going to learn about TBI and PTSD, from our occupational exposures in wartime, are going to help everybody. And there are populations of large interest. So I'd also like the researcher on the street to know that they can partner with the military, and they can, there's lots of opportunities, and there's funding opportunities. And if they're interested, there's many portals you can go to find out more about it.
How do you describe what you do to somebody that you've just met?
I say that my office is charged with ensuring, if you can ever ensure anything, that research that the Army funds is done according to high ethical standards and obeys the regulations. I get to give a lecture about every 6 months to graduating seniors at University of Maryland's nursing program that are in a public health course. And I tell them the story of getting to be able to support an HIV vaccine research study in Thailand, which was an amazing life experience. I guess that's another thing I'm very proud of. And throughout it, try to weave an excitement, about nursing. And so for me, nursing and research protections are just hand in glove. It's another type of advocacy. It's another explaining to your patients about what's happening to them, helping your patients live with what's going on. And so I try to excite them about nurse. And nursing isn't one thing anymore. Nursing is so many things. But nursing is just rocks. And then what you can do in nursing. You can be a researcher. You can be on an IRB. You can be a research nurse and help conduct research. And then you can get your PhD and you can do the research. And then you can oversee research and help other people do research. So the sky's the limit, I get pretty jazzed about it, actually, and try to recruit people all the time, And the Army, I'm your atypical Army. I would love to say I came in for other reasons other than wanting to live in Europe. But God bless that happened because I stayed for all the right reasons. It was just an avocation after a while.
What personality traits or skill sets do you have that have stood you good stead for the length of your career?
Well, I think analytic ability and the ability to listen and take in a lot of information, and I'll use military terms, but then develop alternative courses of action and look at the pros and cons of those. So, that probably some aspect of OCD-ness and perfectionism, which is a curse and a blessing. I guess empathy and caring for what in the health, were patients, but then expanded to subjects. But and a sense of humor, because you could not get through all of life without it, and just liking people. This has been a values clarification exercise for me to kind of reflect back on why you took this road, and why it is exciting every day. I've had other opportunities to move on to different levels of contribution, but I love where I am because I get to read protocols. It's sort of like an intersection of where it's happening. It's not at the level of doing research, but it's helping a lot of others get there. And so I've elected to stay where I am.
Well, thank you very much for taking the time today to sit with me. I am very excited to have your story as part of the Archives of People and Perspectives. Mm-hmm. And on behalf of Primer and Joan Racklin, we appreciate the work that you do. Colonel Brosch, Dr. Brosch, Laura, I really appreciate your input. Thank you.
Thank you.